Okay, we may get a few more come in. I'm Cheryl White, and I'm delighted to welcome all you this evening here on behalf of the worship place and also our respite special friends. And one of the nurses is going to tell you a little bit more about that later. We started with 7 right out here in the foyer, and we now have 30, and we fill up about 2/3 of our great big auxiliary room. So we've really expanded there. Okay, you're in for a treat tonight. Dr. Michael Swallow is a movement disorder neurologist and owner of the Texas Movement Disorder Specialist. A native Texan, he received his BS in education from Baylor University, followed by his Doctor of Medicine at the University of Texas Medical School in Houston. He then left Texas briefly for his neurology training at the University of Michigan in Ann Arbor, and then came back to do medical studies later. He has authored 1 board review book, 6 textbook chapters, and has 5 peer-reviewed publications. Currently, he is clinical assistant professor at Texas A&M Health Center and continues to care for and educate patients with movement disorders, both here in Georgetown and in Waco. And check out the boots. He missed Texas so much he had to come back and get in garb for that. So we're welcome, Dr. Swallow.
All right. Well, that was a very warm and welcome introduction. I appreciate that. So for those of you that have heard me speak before, you all know that I like to keep things very informal. I'm a very simple guy. And really what this is about is answering your questions. And I spoke to several people in preparing for this talk, and I said, well, what would you guys like? Would you like a slideshow? Talking points? What's most meaningful for everyone? And I think the resounding answer was, just talk to us and let us ask questions. And I said, deal, because that's what I enjoy the absolute most. I don't want this to be a lecture, but instead, I want this to be about questions that you may have about Parkinson's disease, and certainly other things we can talk about as well. And then I also said, feel free to just kick me off the stage whenever, because, I could talk about this forever, because this is a very important and dear subject to me. And how many of you are caregivers of someone who has Parkinson's disease? So a fair amount. And then how many of you are patients with Parkinson's disease? A fair amount. So we have a very good blend of both. And I want this to be basically about both of you, the patient and the caregiver. And what I really wanted to talk about today, to at least start us off, but y'all know anything is fair game, is the non-motor features of Parkinson's disease. And so that's something that in my experience, I think really can be much more disabling than even the motor symptoms. So let's talk about that. And again, this is not me lecturing. This is you asking questions, interrupting. This is you raising hands. And because chances are, if you have a question, everyone has a question. And so again, I want you all to feel free. The podium here makes it feel so formal, but I don't want it to be that way. So let me just talk to you a little bit to get us started about non-motor features of Parkinson's. So, for years and years, we really focused on movement. So the tremor, stiffness, and slowness that comes hand in hand with Parkinson's disease. And that was our challenge as a neurology community, is to treat that. However, what we later come to find out is while we have amazing treatments this day and age to treat Parkinson's disease, we really need to focus on the non-motor features of Parkinson's. So what does that even mean? Well, there are things that make our job challenging, and part of that is actually asking patients and caregivers about several things. I'm just going to rattle off things that I usually ask about. Depression, anxiety, loss of smell, loss of taste, drooling, constipation, urinary urgency, thinking and cognition, hallucinations, sleep. All these things that I just rattled off, first of all, I don't want everyone to freak out saying, oh my goodness, am I going to get all those things with Parkinson's? Absolutely not. However, they can happen, and when they do, the important thing for you to know is that each and every one of those things are treatable. We just have to ask you, the patient, and the caregivers have to let us know, the providers. And I always say that when patients don't tell the whole story, look next door to the spouse or significant other, kid, and they will. They'll tell you the full story. And so it's important for us to address each and every one of these issues. And the Michael J. Fox Foundation did a very large survey with over 3,000 people asking about non-motor features of Parkinson's disease. And actually, they found that the non-motor features were much more disabling than the motor features of Parkinson's, which really challenged all of us to really focus on the non-motor features. So having said all that, in summary there, it's important. Number two, it's treatable. Every single thing I mentioned is treatable. But as you've heard me say so many times, or some of you have heard me say so many times, treating Parkinson's disease is at times much more an art than a science. And if you don't ask the right questions, you'll never discover the solution. I think that's kind of the one thing I would leave you with to start. So on that, let's open the floor to specific questions, and I know that that will generate more questions. And if you don't have questions, I certainly have things to talk about. So anyone with a burning question? Yes, ma'am, in the black. So the question is constipation. What causes that, and what can you do about it? So I have a joke amongst my patients that if there's one thing I can do and be successful at it, it's make our patients poop. I could do that, and let's talk about that. So many of you, I don't want to preach to the choir, but many of you know that Parkinson's disease is the second most common neurodegenerative disease, only second to Alzheimer's. So it's not about, do you know someone? Almost everyone knows someone with Parkinson's, but it's a very challenging disorder that by the time they present to me, unfortunately, they've lost 60% of the dopamine in their brain. And dopamine, as you know, is a very important chemical. It helps us to move, of course, but it also helps us to think, to poop, to pee, to you name it. I mean, it's very important part of our life. And so when you don't have that, it's important to supplement that back. So when patients first present with Parkinson's, they present with a loss of smell and constipation, and that can precede the symptoms of Parkinson's a lot of times for 10 to 15 years before they ever develop stiffness, slowness, plus or minus tremor. And so when patients have constipation, it's almost as if your gut has Parkinson's too. So just like your other muscles have Parkinson's when someone can't talk very loudly, or maybe they're walking in a shuffling manner, or maybe they have a tremor and they just can't move as well as they used to, your gut is the same way. And the problem with that, my nemesis, is that every time I give a patient dopamine to supplement their dopamine for their Parkinson's disease, it's in the gut that it's absorbed. And that dopamine has to battle it out with protein and get up to the brain so that your brain can see the dopamine that your body needs. And so, one thing that's very important is to treat the constipation. So, long way of answering your question is what causes the constipation? Just having Parkinson's disease causes the constipation. Doesn't mean that if you're constipated, you'll have Parkinson's, obviously. That goes without saying, but the reverse is true. Certainly, if you have Parkinson's, constipation is very prevalent. And how do we treat it? Well, the simple way that we always like to start off is just diet. So we want to make sure that you're eating a lot of good leafy greens. We want to make sure that you're making sure that you have fiber in your diet. This is the most common problem, making sure that you stay well hydrated. But If all those fail and you're still having constipation, my go-to is an over-the-counter medication called Miralax. It's a laxative, and just to get very downright and honest with all of you, you know, there are two parts to having bowel movements. There's the actual consistency of your stool, and then there's the actual push of the stool out. And so most people tend to focus on the consistency, so they'll take stool softeners, for example, or they'll increase their fiber, and that helps with the stool consistency, but it doesn't help with the push. And so a lot of times you need laxatives for that. If the laxatives, the Miralax, like I said, is a flavorless, odorless powder that you mix in with anything. You usually take it in the evening, and most patients need 1 capful, sometimes 2 capfuls to really do the trick. But let's say that doesn't work. What do you do there? Well, you a lot of times need a combination of things: magnesium, suppositories, other laxatives, combinations of fiber and prunes. You can make prune jelly, prune jam, prune juice. As I said, I could go on and on about this. But why is it important? So many of you probably have figured this out on your own, but some of you will feel that your dopamine just isn't working as well as it used to. And for the caregivers out there, that impacts you too, because that's how many times you're having to give them the dopamine, how many times you're having to help them do this, that, and the other. That all depends on whether or not their dopamine kicks in. And so if you're constipated, again, that dopamine doesn't get absorbed into the gut. And so when you have a bowel movement, patients can literally tell the difference within 30 minutes of having a bowel movement if they're treated, and they feel like their dopamine kicks in so much more readily if they're having good, consistent bowel movements. That's one of my first questions when patients call me in the office and say, my meds just aren't working as well as they used to. The first question is, have you had steady bowel movements? So what does that mean? At least going every other day. If you're on a third day and you still haven't had a bowel movement, probably should call in the other resources to help you have a bowel movement. If all that's still not working, we have prescription medications that we can prescribe. Unfortunately, they're brand name and they tend to be expensive, but a lot of times we can get insurances to cover it because we can say they've tried and failed X, Y, and Z. So again, a lot about bowel movements, but probably one of the most important non-motor features that we treat, because how well you're having bowel movements will impact how well your dopamine kicks in, and therefore how well you can talk, you can think, you can move. So again, very important. So, yes, ma'am, in the front row. If you can, I think they're recording it, so it's helpful to hear.
When my sister was still at home, we had a lot of success with her constipation with smoothies with a lot of greens in them. That was very, very helpful.
I fully support that. So smoothies with grains, basically what you're doing is
Greens.
Grains?
Green
Greens,
vegetables.
sorry. Okay. Well, grains are fiber, so I support that too, and then vegetables. But all you're saying is essentially you have to get creative sometimes and find something that the patient will actually drink or eat, and I agree with that. So whatever it takes, as long as you're having steady bowel movements. Yes, ma'am.
I know that cognitive problems are symptomatic of Parkinson's. Is there any possibility that dopamine could make the cognition, the confusion worse?
Great question. So just to reiterate or remind everyone about the question, it is, what does dopamine do for cognition? Is there a chance that it makes it worse? Does it make it better? What about that? So you're absolutely right. So cognitive concerns are present at times with Parkinson's. Doesn't mean that everyone will develop that, but the nature of Parkinson's is that abnormal protein that builds up in the brain, starts off in the nose and in the gut, and over time it spreads in the brain to eventually it reaches the outside of the brain, and that's when you start to see cognitive issues. What does that mean? That means difficulty processing, judgment, memory. That does not mean walking into a room and forgetting what you went into the room for. I have a 2.5-year-old at home and a 1-year-old, and I do that daily. So it does not mean that, but most of the time, patients will begin to understand when they have cognitive issues, and caregivers most certainly will be able to notice when there are cognitive issues. And that tends to happen later in the course of the disease. It's treated with boosting a chemical in the brain called acetylcholine, and we have several medications that can do that. And we have another medication called memantine or Namenda that can help with memory and cognition as well. So, to get to your question, what does dopamine do for that? Well, it can do both, and let me explain each. So, any patient, and certainly caregivers that have noticed this about their loved one, can testify that if they are off, which means their meds are not kicking in appropriately, they feel like they're just not moving well, stiffness, slowness, tremor, they are not able to think as clearly, as rapidly, as smoothly as when they're in the on state. And so you can see that. You can talk to a patient when they're down on their dopamine, supplement their dopamine, give them their dopamine back to them, wait 30 minutes, see them in the on state, and you'll notice a clear difference talking to them cognitively. So no doubt when you're off, your dopamine can help you with your cognition to some extent. Now, sometimes the medications that we give patients, some dopamine meds more than others, can make you very sleepy and can actually cause hallucinations and things like that. That's why we have to always balance the sleepiness and side effects with the benefit of the medication. And so that is a fine dance that we always are working toward, okay? So more often than not, though, dopamine will not worsen the cognition, with the exception of a couple of meds, such as amantadine, which is a medicine that we sometimes use for people who are dyskinetic or moving too much. Amantadine can cause hallucinations. And then some of those dopamine agonists out there, the pramipexole, ropinirole, Nupropatch, again, that doesn't become dopamine in the brain, but it mimics dopamine, and so those can be notorious for causing hallucinations. But again, as far as the loss of memory and things like that, dopamine doesn't really cause worsening of that. If anything, it can kind of help that. So, good question. Other questions? Yes, ma'am. Yeah, so the question is, what is the relationship between Parkinson's and sleeping? So here's a fun part of my job. So what will you, the patient, tell me? I can't sleep. Then what is my job? I've got to figure out why. So let's dive into that a little bit. So if someone tells me they can't sleep, the first step is asking, do you have trouble going to sleep or do you have trouble staying to sleep? Most patients don't have trouble going to sleep. Most patients get to sleep right away. It's the staying asleep part. Then the question becomes, well, when do you wake up? For those Parkinson's patients who say, I wake up at 2, 3, 4 a.m., a lot of times what that means is that your dopamine is actually wearing off at that time. And so sometimes patients may have some curling or some twisting of their arm, maybe some cramping of their arm or leg. That's called wearing off dystonia. And that's a very common thing that we have, or that we see. Also easily fixed with dopamine. Sometimes patients will say, I don't know, I just wake up. My mind just wakes up and I say, well, since I'm up, I have to go pee, and so I'll go pee, but then I can't fall back asleep. Well, that's a little bit tougher, but if it's at that 2, 3, and 4 a.m., a lot of times I still would be willing to bet it's going to be wearing off of dopamine. The other thing that can sometimes happen at that time, if patients are consistently waking up very early, sometimes depression and anxiety can actually cause people to wake up early. It's called early morning awakening. And so again, yet another thing that we address. Sometimes it's because of something called REM sleep behavior disorder, or RBD. So how many of you caregivers have been punched or kicked by your spouse? Half the room raises their hand. So obviously they're not doing that on purpose. It's an accident, and it's part of Parkinson's disease. So let's talk about that just briefly. So whenever we are asleep and we are in our dream sleep, our rapid eye movement sleep, we should not be able to move. We should be paralyzed. And that's good, because if a lion's chasing after me in my dreams, I should not be able to get up and take off running down the hall. However, in Parkinson's, you actually do. You actually move your arms and your legs, and guys tend to get in fights in their dreams, and so you actually will punch or kick. Ladies tend to get in arguments in their dreams, and they actually will scream out. And that's very common in Parkinson's, and again, can precede the diagnosis of Parkinson's by 10 to 15 years. Also, very treatable with simply melatonin. Over-the-counter melatonin will actually go to the spot in your brain and suppress that the REM sleep behavior disorder. And then there are also prescriptions like clonazepam, which is a benzodiazepine that we use to treat that. Yes, ma'am.
If somebody with Parkinson's was on melatonin for a long time, they're having a lot of problems with sleep, and there appeared to be no benefit to the melatonin, could that still be helping, even if they don't sleep more?
No, I would say it depends on what you're trying to treat with the melatonin. If it's the REM sleep behavior disorder and it's not helping, then you need to move on to a different therapy if it's truly not helping. Although, when I say truly not helping, remember that we go up to 20 milligrams with melatonin. So most of the time I tell patients to start off with 5 milligrams, and then they can increase up to 20 milligrams. And the good thing about melatonin, it doesn't really make you feel hungover per se when you wake up, unlike some sleeping medications. To continue on that thought with the REM sleep behavior disorder, sometimes we do need to prescribe benzodiazepines or clonazepam for that. Other times when patients tell me that they can't sleep, sometimes it's because of a primary sleep disorder. We're very blessed here in Georgetown that we have Dr. Darnell, who is a neurologist, actually, who's trained in neurology but specializes in sleep. And so he understands Parkinson's perhaps better than most sleep doctors, because he's actually a neurologist. And so he can do a sleep study and make sure that you don't have something like obstructive sleep apnea that could cause you to wake up. So again, so many different causes, and that's just to name a few, of difficulty with sleep. But I always say if you're acting out your dreams, you're not getting the deep, restful, restorative sleep that you need. And then what happens? The next day, everything's worse. Everything. Your mind's worse, your tremor's worse, everything. And so sleep is a neglected area that we tend not to address, but we should be addressing, because, again, that's also a very disabling part of Parkinson's, but yet every single thing I mentioned is treatable. But patients have to be patient as we kind of navigate that course, because a lot of times it's not clear-cut what it is. And then you heard me talk about the art of treating Parkinson's. So it's not uncommon for me to see patients who talk to their primary care doctors about, I can't sleep. And so what's the first thing that they do? They give you a sleeping pill, right? Well, in Parkinson's, and you already know this, but in Parkinson's, again, it's different. So you have to ask the right questions. So when do you wake up? Are you having wearing off symptoms? Could that be dopamine? In that case, you don't need a sleeping pill. You need more dopamine. And so we can do that by giving patients extended release dopamine at bedtime. There's a branded medication named Rytari that's got immediate and extended release, beads and a capsule, and that tends to work very well at night. And sometimes we even have patients that are very sensitive that even require the dopamine pump to keep them 24-hour continuous delivery of dopamine, just because they wear off so frequently in the middle of the night. And then just to piggyback off of that, a lot of times when I first diagnose someone with Parkinson's, they say, Dr. Swallow, why do you only have me take it every 4 hours in the daytime. How come I don't need any dopamine at night? Well, remember that most of the time you think of dopamine kind of like gasoline in a gas tank. So if you're awake and you're up and at 'em and you're doing things, you're using that gas. And so you need to restore or refill that gas tank with the dopamine. But at night, you're not using as much dopamine. So most patients still have enough reserve in their brain to give them back some dopamine if they need it at night. But if they don't, that's where I come in and I help them. So again, great question about sleep. Yes, ma'am. The question is, does Azilect have dopamine in it? And yes, it actually does. So let's talk about the different classes of medications a little bit. Because you don't sleep. Okay, let's talk about that. So Azilect, or Rasegeline as it's now generic, is what's called an MAOB inhibitor. And what that does is it actually keeps more dopamine around for the brain to see. So it prevents the breakdown of dopamine. So you'll find that we have to get very strategic when we're treating Parkinson's. So we don't simply just give you one pill to cover everything. A lot of times we need to use several different types of medicine in Parkinson's just to stimulate different receptors in the brain to keep you smooth and steady. So what Azilect does is it keeps more dopamine around a little bit longer so it's not broken down. That way your brain can see that. However, it also depends on what Parkinsonism symptoms you have, because Azilect is not one of those very robust medications that, patients start Azilect and they say, oh my goodness, my tremor completely stopped. I don't have that anymore. I can move so much better now. Again, it's kind of a behind-the-scenes medication. So I like to think of Azilect as being one of those meds where I'm having someone on dopamine already, and they're having some wearing off about 30 minutes or so before their next dose, and I need to add something just a little bit to smooth things out. That's a good thing for Azilect. Or if they don't have a lot of symptoms, period, and they have very mild symptoms, Azilect is a great first-line medication for patients who have very mild symptoms of Parkinsonism. My young patients, 30, 40, even 50-year-old patients with Parkinson's disease, a lot of times when you start them on Azilect, they have a lot of dystonia, so that twisting, curling, cramping of arm or leg. And a lot of times Azilect, anecdotally, they tell me that they feel a lot better with that, with the Azilect. But again, don't think of any of these medications as a sleeping pill, because again, we have to kind of parse through what's actually causing someone to be awake. If it truly is the dopamine, then Azilect is not my go-to to supplement your dopamine at night so that it's sticking around, for your dopamine to be steady. Yes, ma'am, in the back. Sure. If you just repeat it, if it's okay, I can go ahead and repeat your questions. Sure. So the question, let's answer that one first. So what type of pain medication can you take if you're active and you're doing things? When you get sore, what do you do? Well, in general, I would say you can take most pain medications just like anybody else can. There are a couple of caveats to that, though. So if you're sore, I can't tell you how many phone calls I get in the winter months from my patients that really feel like they're aching, and that's because it's cold weather outside. So that is usually an inflammatory reaction. You can always take some anti-inflammatories like Motrin or Aleve or something like that. Most patients need to take that with food. Now, understand I'm speaking in general, so every patient has, certain things. If you have ulcers of the stomach and things like that, obviously you can't take those meds. So I'm talking about in general, but anti-inflammatories are great. If you need to step it up, though, and your doctors need to give you something else like opiate medications or narcotic medications, certainly those can be used for a short term. The problem in Parkinson's disease with those medications is they can also cause confusion. They can worsen confusion. And what we typically see is when a patient takes even a small dose of that, it lingers, which means meds don't tend to get absorbed like they do in most patients with from Parkinson's versus patients without Parkinson's. Things linger, and so it can really cause some long-lasting effects there, more so than for most people. There is one medication called tramadol or Ultram, and again, that's safe to take in Parkinson's as well. But if you are on an MAOB inhibitor like racegiline, selegiline, or the new one, Xadago, you don't want to combine them with tramadol. That's the one caveat there. Any pain medication like tramadol or narcotics can worsen constipation. So yet another thing in our Parkinson's patients that we have to pay careful attention to, especially when I usually see that happen is after a surgery, like an outpatient procedure. Your surgeon will give you a small dose of medication, pain meds to take home with you, but yet we'll get phone calls right after that their constipation worsens, and that's because of the pain meds. So you just have to, take very special care of that as well.
Somewhere I was told to just take ibuprofen. I took 2 leaves the other night when we were moving some stuff. Anyway, I was hurting, and it stopped the pain, but it really messed up my medication. I'm on Rotari.
It shouldn't interact or do anything with your medication, for sure. No interactions there, so maybe coincidental there, perhaps. I will say this. A lot of times, you heard me talk about kind of how it feels to be off when your meds aren't working well. It's also not uncommon to have patients tell me that they have pain whenever they're in the off state. So when we have patients complain of a lot of pain of their joints and things like that, many of you who are my patients know my next question is, when? All the time. No, really, what time of the day? Have you ever written it down? There's a pattern to it, almost always. And when you look at that, a lot of times patients will see that it's right before they're due for their next dose of dopamine. It's not uncommon for patients to present to me after they've had orthopedic surgeries of their neck and of their shoulder and things like that. And it's only until someone is astute enough to notice that you're not swinging your arm when you walk, or you're not talking as loudly. I wonder if you have Parkinson's, and lo and behold, you give someone dopamine and bam, their pain goes away, whereas the surgery didn't help it at all. So the moral of that story is that even in Parkinson's, you can have what looks like orthopedic pain, but it's actually related to your dopamine. So you have to always write down when your pain is and look at your dopamine doses and see if that's happening right before you're due for a dopamine dose. Excellent point.
The sleeping when you wake up at 2, 3, 4, is it possible to take more medication at that time and go to sleep?
Yes, ma'am. So the question is, can you take more dopamine, for example, when you wake up at 2, 3, 4 a.m.? Sure. Have to talk to your doctor, of course, but yeah, in the right situation there is. Our goal, though, is to make it more convenient for you, not inconvenient. So it's not super convenient to have to wake up and take more meds. What we'd like to do is to give you a medicine before you go to bed to where you still have dopamine lingering in your system there and keep you pretty steady until maybe first thing in the morning when you need to take your next dose. That's kind of the ideal situation. But I definitely have patients that need to wake up in the middle of the night to take more dopamine.
About the Azilect? Can you take it for years? I took it for 6 years, something like that, and it was very effective. Cost-wise, I stopped,
Mm-hmm. So yes, you can continue to take all these medications for years on end because that's a common myth out there is that dopamine stops working after a period of time. So remember, dopamine never stops working. It's simply that your sweet spot gets smaller with Parkinson's and more challenging to keep it steady. So you can take medicines like Azilect and all those for years on end, and that's completely fine. And you bring up another very important point, and that's cost of brand name medications. Even when Azilect went generic, it didn't change the price all that much. That's a soapbox that I shouldn't be on a pulpit right now. But anyhow, my one little caveat there is remember that a lot of the brand name medications that you may take for Parkinson's, your doctors can have you fill out forms to send in to the company. And there are several places with grants that can actually give you assistance when you're in the donut hole, for example, for those of you who have Medicare, which is most of our patients. There are all kinds of things that they can do, and it's not all financial based, by the way. And so there are all kinds of options. I had one patient that was taking Rytari and was paying over $500 a month for Rytari, and I didn't know it because they never told me. And then I said, well, did you sign up for the My Rytari program? And they said, no, what's that? And so we had them sign the form, and all it is just giving the company permission to call your insurance, get their benefits, and things like that. And it dropped his copay every month down to $20. You know, so there are things like that that you can do. And remember, your doctors are working on your behalf to fill out pages and pages of forms and spend time on the phone with insurance companies. That's why, you know, our nurses and others have no hair when you see them, as they're always pulling out their hair. So just remember that, you know, we're here to help you get the medications you need. And if patients come to me and say, you know, doc, I can't afford that, then that's not an option for them. And I have to find other options for my patients. And I always say, even if you're a millionaire, it's not right to spend that much money when you have a limited income every month on one med. You know, we need to be more creative to help you given that constraint. So, yes, ma'am.
Can a patient who has MSA use dopamine?
Great question. So let's talk about MSA. MSA is multiple system atrophy, and that is a cousin of Parkinson's disease. So, you know, you may have heard, how many of you have heard of Parkinsonism? Yeah, so most of you. So let me explain that. Parkinsonism is a grab bag term that simply means a few things: stiffness, slowness, maybe a little bit of tremor. There are many things that cause Parkinsonism. Medications can block dopamine and make someone look like they have Parkinson's disease. That's called drug-induced Parkinsonism. MSA, a cousin of Parkinson's disease, same abnormal protein, but just in a different spot in the brain, can cause things like plummeting blood pressure to go way down, dizziness, lightheadedness, urinary urgency, constipation, dry mouth, dry eyes. On top of that, Parkinsonism, or maybe clumsiness, that's not really as responsive to dopamine, okay? You can still have some of those symptoms in Parkinson's disease. That doesn't mean that you all have a cousin of Parkinson's disease, but MSA tends to have those findings a lot earlier in the course. Up to 30% of patients with cousins of Parkinson's, like MSA, can present or actually improve with dopamine. But the improvement is usually a little less robust than in Parkinson's disease. So in almost all my patients with MSA, for example, I still will try dopamine because many of them will actually get somewhat better on the dopamine. It's just not as robust as those who have bread and butter, plain old Parkinson's. Yes, ma'am. Sure, the question is for the patients who have cognitive problems and psychosis later on in the course of the disease, can I speak to what sedatives and other sedating medications that can be used? What's most appropriate for them? When someone is having, let's say, hallucinations, it may be people, it may be animals, a number of different things patients describe. It may be delusions of infidelity. Oh, my spouse is cheating on me. I know it. Who are you with? We've been married for 63 years. What do you think? You know, doesn't matter. It's brain playing tricks on patients, and we try to be open and honest about that with our patients and caregivers. The other thing is there's someone in my pastor stealing my equipment. I know they're out there. They're stealing my equipment. That's something we hear a lot of in patients that have Parkinson's, dementia, for example. The good thing is all those things are treatable too, okay? So let's talk a little bit about the treatment. Now, if someone tells me in my office, do you ever see things that other people can't see? Yes, I do from time to time. I see shadows that are fleeting, or sometimes I see that plant right there. That's my unborn, or that's my previously born child. We lost them early on, but they comfort me. I know that he's not really there, but it makes me feel better to know that he's there. These are all real examples. We don't necessarily treat those because they're not bothersome to the patient. To caregivers, bothersome, right? I get it. But to the patient, it can actually be comforting sometimes. We don't treat that. That is opposed to there's someone breaking into my house and I'm going to go shoot them. Okay? I've heard that. There's no one there. Okay? Or there's someone stealing something, or again, the infidelity delusions. That's different. So when we treat those, we have several options. The first one is a medicine called Seroquel or quetiapine. That is a medicine that is given to some patients who have psychosis, but it doesn't block dopamine as badly as the other meds do because it still is able to treat the psychosis without worsening the Parkinson's. So what happens when you're low on dopamine and then you give someone some antipsychotics that block dopamine? It makes your Parkinson's worse. I just saw a gentleman today in my Waco office who he has a cousin of Parkinson's disease called dementia with Lewy bodies, and he was having some behavioral issues, and his doctors at his nursing home put him on risperidone. Risperidone actually blocks dopamine, and immediately he started drooling, his walking got worse, he couldn't get up out of his chair, he couldn't talk or communicate. Helps with the psychosis, but it worsens everything else about this gentleman's quality of life. But again, nobody even suspects that that's the wrong medication. Again, that art of treating those who have Parkinson's disease and the cousins of Parkinson's. So there are some meds that cause worsening of Parkinsonism, but the safe one is quetiapine or Seroquel. There's another one called clozaril or clozapine. That one's a little more challenging to give because we have to get every 2 week to every 1 month blood levels and blood counts just to make sure your levels are good. But we certainly use that if we need to. And then within the last year or two, there's a new medication out called pimavanserin or Nuplazid. Now that they have commercials on TV, a lot of patients have seen that. A lot of patients have also become very frightened by saying, oh my goodness, am I going to have those hallucinations? But I look at it as a positive thing because it gives us a platform that you and I can talk about that and we can educate, on what does that mean and what do we do about it when we have psychosis. Benzodiazepines, tranquilizers, if you will, that's something that we do use time to time, again, as I've already mentioned, to treat REM sleep behavior disorder, but that can worsen agitation and confusion too. That's why we always have to weigh that risk and benefit of giving that medication to patients. But again, at lower doses, it tends to be okay. So in general, in summary there, to treat psychosis and Parkinson's disease, quetiapine or Seroquel, clozaril or clozapine, and pimavanserin or Nuplazid. Those are the 3 ways that we treat psychosis. The other thing is we want to make sure it's not something I'm doing to you, like having you on a amantadine or a dopamine agonist that's known for causing hallucinations. We want to make sure that we drop those medicines very slowly. And then the other thing is making sure that you don't have what's called a urinary tract infection, which is the first thing that we always think of when you have an acute change or worsening in your mental state. That's the first thing is, have you checked your urine? Well, I don't have dark or foul-smelling urine. It doesn't hurt when I pee. Unfortunately, in our patients with Parkinson's, it doesn't matter. It can still cause a urinary tract infection, and lo and behold, you treat that with some antibiotics, and it clears up nicely. And so we always have to screen and ask for that. Yes, ma'am? it's a very real world and good example. So just to repeat that for everyone, what happens when you have a caregiver or a loved one, a patient or a loved one who is confused, maybe demented, and they argue with you, you try to correct them or maybe redirect them, but it escalates matters and it makes things worse. That's a great question. It's very challenging. In general, it's a fine line, and only you and your loved ones know that best, what that line is. I tend to be under the mindset that I get some families that pull me outside in the room, away from the patient, and says, I don't want to say this in front of my loved one, but, X, Y, Z, we're having these problems. Don't let them know I told you. I understand where they're coming from, but in general, the best way is to actually get everything out in the open. And thankfully, that's what I'm here for. For some reason, it is less offensive coming from me when I'm there than even the person who they love the most. However, in that situation that you speak of, that's a little different. When you have someone that has poor insight into whatever you're referring to, fill in the blank, could be, you're in Georgetown, Texas. No, I'm not. I'm in Baltimore, where I grew up. I mean, whatever the case may be. I'm just making things up. But if you see that it's escalating things as you try to reorient them, for example, or correct them in some cases, and you see that it's escalating things, in that case, I would not continue to escalate things. And what that may be an indication is that we need to actually treat some of that behavior and confusion. Because while we don't want patients to be asleep and out of it, we certainly don't want them to be fearful, angry, or scared. And so again, we have to find that balance. Yeah. Yeah. So you bring up some really good points. The first thing I think, and probably the most important thing you said there, is you need prayer, right? You got to get through it. And, caregivers need just as much prayer as patients, for sure. Yep. Yeah. Exactly. Exactly. Yeah. And then the second thing I think that's important that you said there was that when someone doesn't have good insight, you really do have to let it roll off. And trust me, even as a doctor, I take it to heart when patients say mean and angry things, and they do. Even despite my best efforts and attention to them, you really have to try to let it roll off and realize that their brain is not working well. Yeah, when our 2-year-olds scream bloody murder and say things, we say, oh, they're growing, they're learning. Well, in the same token there, when our loved ones who have dementia and have poor insight say things, again, their brain is not making sense to them. And so we have to be mindful of that. The big thing there is, and you bring up visiting angels, the big thing there is making sure that you as caregivers get at least a little bit of respite for yourself, a little time by yourself. Even 1 hour a week could be enough to restore your gas tank and make it to where you can make it to the next week. You just have to take some time for yourself. And maybe that's worth, paying $20 for an hour's free worth of time where you can just be alone, go to the grocery store by yourself, go with the girls or the guys by yourself, go to church and pray. Whatever it is that you need to do to restore yourself, you need to do that. And don't neglect. They'll be okay. They will, they always are. You just have to, I think I heard someone today say, this is the first time I've been able to get a caregiver to come where I can actually attend one of these things. And that's good for you. And I'm glad that whoever you are, you were able to do that. Yes, sir, in the back. Well, sometimes the question is, and the illustration of taking two medications together where you shouldn't take at the same time, sometimes doctors will prescribe it without knowing. Sometimes pharmacies will should catch it but don't catch it. Again, thankfully there are many avenues of checks and balances. As we prescribe those meds, such as resegeline, as I mentioned, and there are a few different meds you want to try to avoid with resegeline and selegiline and those MAOB inhibitors. Your doctor should hopefully give you that, a list. Now, I will say that almost every medicine in Parkinson's disease, except for maybe that one, the MAOB inhibitors, there really aren't interactions with anything. So that's the good thing. It makes it very easy. However, there are medications, and just in general with Parkinson's, that you shouldn't take. As I already mentioned, the gentleman who was in the rest home that was taking an antipsychotic that makes Parkinson's meds or Parkinsonism worse. A lot of times, those are part of an order set where when patients are admitted to a hospital, let's say after surgery, and you have nausea, there will be meds on there to help with nausea that actually are contraindicated in Parkinson's disease. So once I moved to Georgetown, I worked with St. David's Georgetown to actually help develop a screen where if a patient has a diagnosis of Parkinson's and they're admitted to the hospital, there is a flag that comes up that say, these meds shouldn't be given or prescribed. Because again, remember, a lot of times nurses and doctors don't even fully understand what to do and not to do in Parkinson's disease. You all are the biggest advocate for your loved one and yourselves with Parkinson's disease because, again, you're in it every day and you come to things like this and you learn more about things, whereas sometimes your doctors, they haven't learned or heard about this stuff since medical school, So, again, and plus things are always changing. So, again, it's important to be well informed. So, yes, ma'am. Sounds like me from time to time. So the question was, what are some practical things you can do to kind of coexist or cope, I should say, is a better way to put it, with memory issues? So one thing that I find to be very helpful is, and patients don't often like this, but there are detailed battery of tests that you can take called neuropsychometric testing or neuropsychological testing. And unfortunately, it takes several hours to do, but there are tons of tests that patients can take at the direction of a neuropsychologist to know objectively what is wrong with their brain. What is the strength? What is the weakness going on in the brain? So let me give you an example. Some patients with their Parkinson's and cognitive issues have a very good visual spatial recognition, meaning visually they don't have any impairment there. However, verbal recognition, auditory recognition, and memory is not good. If we see that pattern on testing, we know that the best way to prompt patients to take their medicine, do this, that, and the other, are visual clues and visual cues. So post-it notes, for example. Maybe a beeping watch to remind them with an alarm that flashes what they need to do. Things like that. That's contrasted with patients with poor visual spatial cues that you actually need to use auditory over and over and over to remind them. But if you have someone with poor verbal understanding, what is our natural tendency to do? Remind them, say it over and over again. But it's not sinking in because that part of the brain's not working right. So I often find that neuropsych testing can be to the caregiver's advantage because it actually can help delineate what are the strengths and what are the weaknesses, and then help you kind of, in your own situation, come up with a game plan. There are all sorts of scenarios. You name it, we face it. How do I keep my loved one from driving? When they know they shouldn't, or maybe they don't know they shouldn't drive, but yet we all know it's not safe for them to drive. I mean, sometimes we have to disconnect battery cables. Sometimes we have to sell cars, Those are extreme examples, but there are so many different ways to cope with that. But I think the moral of the story is each patient is different, and so we have to use any tool that we can to find out the best plan for them. Sometimes social workers, physical therapists, occupational therapists, home health agencies can all be very helpful with some of those things as well. Because like our visiting angels, they're there, kind of seeing things, and you can get a good sense as to what's working and what doesn't. And just like in the lady's case of the person she cares for, she knows what's going to escalate and what's going to just calm the patient down. The same is true when it comes to cognitive issues. You know what you've already learned, chances are, what has worked and what doesn't work. And so again, you just have to do more of the same. But there is more method to the madness. In other words, it's not just by chance that something's working and not working. It's actually how their brain is working that helps it succeed. Yes, ma'am. Yep. Yep. Great feedback. Yes. Yeah. And she's not. Yeah, absolutely. In the back. The question is, what happens if you don't get your meds on time when you go someplace? If you get injured, for example, you don't have your meds with you, what happens? Could you die from that? That would be pretty rare to actually die from something like that if you don't have your meds. However, there have certainly been cases, and even in my own experience, I've seen that patients have not had their dopamine for a prolonged period of time, and they can develop fever, stiffness, confusion, high blood pressure, and require hospitalization that causes muscle breakdown, kidney damage, things like that. It can be very harmful if you don't take your meds. That's why we tell patients never stop taking your dopamine suddenly, because it's the same as if you block it. If you stop taking your dopamine suddenly, it's the same as if you blocked the dopamine, and that can be very harmful. However, thankfully, our body is a little more forgiving. So in that particular situation, chances are, you would get checked out, and then hopefully somebody would come to your rescue and say, she needs her Parkinson's meds, or they would be able to call a pharmacy and get all your medications. As long as you're getting some dopamine, you should be okay. Doesn't mean you'll be comfortable from a Parkinson's standpoint, but it'll at least keep you out of the danger zone, if you will. I've definitely seen patients go in for surgery, can't take anything by mouth, not have their meds, or it gets overlooked, and then they get into danger's way that way, So the question was, sometimes I occasionally get flushing or redness in my face. Is that high blood pressure? Well, it can be, certainly. But the other thing in Parkinson's that it can be is actually wearing off. So it's not uncommon for patients, as their dopamine levels are starting to wear off, that they may get panicky in the inside, feel anxious, nervous, uneasy. They may have sweats. They may start sweating profusely. Ladies think that they're going through menopause again. It's not, it's just your dopamine wearing off, but that's very common. So what happens when you tell a primary care doctor that you're getting anxious or panicky? They give you a Xanax or something like that. Oh, not in Parkinson's, right? It's all about that dopamine. So again, that's the first clue, perhaps, that our dopamine levels are falling. So again, the same thing with all these symptoms. You write it down, the time, then we look at the pattern to see, is there a certain time that you're getting flushed, sweaty, panicky, anxious, and then usually that means that we need to make an adjustment to the medication. Yes, ma'am. Good question. The question is, how often do you need to repeat that detailed memory testing? And there's no cookie cutter answer there, thank goodness. Nothing standardized or anything like that. It's just a matter of, do you need to? So it depends on what questions. I mean, I never like to subject anybody to that duration of testing. So we always say, what questions are we trying to answer? What's our goal of getting the test? If I'm specifically trying to figure out the strengths versus the weaknesses and help our caregivers out, it's worth it. If I'm thinking about whether or not they're a candidate for deep brain stimulation surgery, worth it. We need to know that information. If I'm just doing it if we know there's already memory issues, cognitive issues, and I'm doing it just because, not worth it. Yeah, because it's not going to help or change our management at that point. So, how are we doing on time? Okay, y'all just kick me off the stage. I want to be respectful to our next speaker. All right. Yes, ma'am. To answer your first question, do I need an EKG before I start Nuplazid? If you read the FDA label, the answer is yes. However, in practice, most movement disorder specialists and those others who prescribe it don't necessarily get an EKG before they start Nuplazid. The reason why we talk about that, you can have something called a prolonged QT interval, and we know that through the studies that it actually doesn't prolong your interval that much. So what we're worried about is starting a medicine like Nuplazid in someone with a genetic heart rhythm abnormality. I'm not talking about atrial fibrillation or something that you acquire with time. I'm talking about those young people that are born with Wolff-Parkinson-White, not related to Parkinson's disease, or some other abnormality of their heart electrical system where there's an issue. Second question, can you transition someone with psychosis who's on another medication to Nuplazid? The answer is most certainly. Nuplazid can take about 4 weeks to really kick in, so we always tell patients it's not a quick fix. However, most patients need to be on both eventually of Nuplazid and the other medications. Now that we have Nuplazid, it's far more common now to see patients begin Nuplazid and then later on, if they need to, be on the other medicines. Nuplazid is definitely safer to start first than the other meds that we use for psychosis. Now that we have Nuplazid, we waited an awful long time to get Nuplazid. So, yes, ma'am, in the back. How do you find out about clinical trials? Is that what you're asking? Okay. Good question. So what are clinical trials? Clinical trials are where there's maybe something new for a condition or a treatment. As you know, every drug or every medication, in the case of a medicine trial, there have been patients just like yourselves that have done the hard work beforehand to make sure that it's safe, to make sure that it works. How do we know what dose to start? And they've done that. It's called phase trials. So phase 2 trial is to make sure it's safe. Phase 3 trial is to find out the actual dose and efficacy. Everything has been vetted by the FDA before it's actually FDA approved through clinical trials. So there are new things coming out for Parkinson's disease. Some medications that are proposed to slow the progression of Parkinson's disease, maybe even reverse Parkinson's disease, all kinds of things for that matter. The places that do those trials are usually clinical centers of excellence and places that have large movement disorder centers. You can usually find those on the Michael J. Fox Trial Finder or clinicaltrials.gov, G-O-V. That's a good place. Right here in Central Texas, there's a colleague of mine, Dr. Beth Peckham. She does a lot of clinical trials. I help Dr. Peckham do some trials. Previously, where I used to work, I did some clinical trials before private practice. And then outside of those places, it's really the large centers like Dallas, Houston, that offer those clinical trials for movement disorders. A couple more questions perhaps, and then we'll maybe wrap up my portion. So let's in the back here. Great question, stem cells. So I actually get this question on a daily basis, pretty much. There is a study going on right now at my old alma mater, UT Houston, where we're looking at stem cells and Parkinson's disease. Remember, though, that stem cells in Parkinson's disease is still very early in its time course. So we are still not sure exactly where to inject the stem cells, what dose to inject the stem cells, and even what type of stem cells, for that matter, really make a difference, even if it does make a difference. However, the theory behind it is wonderful, and we definitely need to look at it more thoroughly. And so certainly there are trials being done to do just that, not just in Parkinson's, but in a number of neurological conditions. I feel this way now and will continue to say I do not recommend going to other countries, as we have some patients do, go to Mexico or Germany and other places and get stem cells. Talked to a patient today whose loved one went to Mexico and had stem cell implants for $30,000. That doesn't sound right, and it's not. And so I don't recommend that, but I do think there's going to be something to that. Just to go ahead and say this, because I know that some of you are thinking about it, but I'll go ahead and say it anyways. CBD oil. We get a lot of questions about marijuana, CBD oil, even from our residents here in Sun City. We get a lot of those questions, and so let's talk about that. So CBD is the less psychoactive component of cannabis or marijuana. THC is the psychoactive component. CBD is another byproduct. CBD can be very helpful in things like anxiety. There's a famous video floating around the social media of a person with Parkinson's who's super dyskinetic, and they take CBD or maybe even marijuana, and a few minutes later they're completely calm, cool, collected, and they're not moving or dyskinetic at all. It's a little bit misleading, because remember that, again, when you're calm, what happens? Tremor gets better, dyskinesia gets better. However, there is some calming effect of CBD. The AAN, just this week, the American Academy of Neurology, published a statement saying that more studies are needed before we can confidently say that things like CBD, THC, marijuana, things like that are truly effective. The only studies we have in the neurology field are for two things: spasticity and severe refractory epilepsy or seizures. We do know that CBD can be very effective in some of those patients, but the jury is still out in Parkinson's, but we're certainly looking at that, because, again, we want to do whatever it takes to get patients' symptoms under control. So with that, I think I know some of you probably still have questions, but let me just leave one bit of advice for you, and I always say this. Remember that just because you may have Parkinson's disease or know someone with Parkinson's disease doesn't mean that you have to be miserable with Parkinson's disease. It's a very treatable condition in this day and age. And remember, it's my job and other movement disorder specialists' job, other neurologists' job, to make sure that we're doing anything and everything we can to treat your Parkinson's disease. So I want to leave you with that bit of hope that now is the time, if you're going to have Parkinson's disease, it's now, because we're very blessed that we have wonderful options to treat Parkinson's disease. Again, it's more of an art than a science at times, but we're very good at what we do. And we're very successful at really treating this horrific condition and making it even less of an inconvenience as it already is. I appreciate you all listening to me ramble and go on and on. I hope this was somewhat informative for you, and I appreciate the invitation for having me here. Thanks again.
Thank you very much, Dr. Swallow. And he has numbers how you can reach him and his staff and get extra information if you need to. Okay, this next lady that's going to come is a friend of mine. Erin Barrett is a community outreach and education nurse for a local group of Alzheimer and senior care-related companies. Erin committed to nursing 25 years ago after going on several medical mission trips with Medico. She's worked in the community in outreach, diabetes education, chronic disease management, and medical surgical nursing. And I'm learning from her all the time different things when we get together. She spent the last 15 years at St. David's Hospital System in Round Rock, and then also in Georgetown. And her last 6 years she spent in case management and discharge planning. In her current position, she spends much of her time helping people find resources and services that facilitate home caregiving for individuals with Alzheimer's. And she's going to speak to that a little bit this evening with her handout. Her parents have lived here several years in Sun City, and she has availed herself of going to some of the programs we have and different things out here. So she's well versed in our age.
Put my notes in order here because I was taking notes on the back of my notes for my speech. Thank you so much for having me here tonight. It's a lighter subject coming on the tails of what I thought was such an informative discussion on Parkinson's. The movement disorders are really complex, and no matter how many times I'm reading about it, I love sitting down and listening and just taking notes and reinforcing some things that I've heard, but I just cannot remember. So I found that sitting here tonight, this is my me time. I'm a special needs mom, I'm a nurse, and everybody wears multiple hats in this audience, I know. And so sitting here and listening and learning was real relaxing to me. And for some reason, I found that getting ready for this presentation was not relaxing. I'm better in small groups. I meet with people in my office, and we try to triage strategies for home care. And I was trying to figure out, why am I getting so nervous about this presentation? And I realized it's a squishy subject. It's not a lot of facts and figures to throw at people, which is, I find, easier to craft into a talk. It's resources, suggestions, ideas. And I don't know what's going to make a difference in your caregiving journey. All of us are real different. Our needs are real different. What we do at home is different. The person we care for and care partner with makes a big difference in what's going to help us stay at home and stay at home for a long time. It's a lot different than having a symptom and saying, oh, there's a med for that. You have to identify a need and come up with something in the community that can meet that need. So I'm hoping, I'm going to try to keep this to the short side of 30 minutes, because I know you guys have been here a while, but I'm going to go through a list that I've compiled over the past year of the non-traditional things. I'm not going to go over home health companies. I'm not going to go over in-home caregivers. I'm going to go over the things that we don't usually think about. When you came in, we should have been given a packet. It's a 10-page edited packet with all my notes. So you don't have to scribble anything down. And my goal is, by the end of this 30-minute period, I've introduced 2 different things, maybe that you hadn't heard of, that you can take home with you, and it'll help with everything you're dealing with. Like I said, we all wear many hats, and we need to accept help. The first page of I put as the Caregiver's Pledge. And I'm great about handing this out. There's somebody else in the audience who's real great about handing out information and not using it. And he knows who he is, because we talk about this all the time. My 3 I will statements for caregiving that are my favorite are: number 1, I'm going to understand that I can't care for anyone else if I don't care for myself first. And I will keep an image in my mind of putting on the oxygen mask. The caregiver puts it on first. And if you're here with your care partner, both of you got to look out for each other. One has to offer care, but the hardest thing is to be the one who's accepting it, I think. It's easy. I'm real good about being the boss. I'm really bad about accepting advice and suggestions. Number 7, I will say yes. Stop laughing, Kelly. I will say yes when someone offers to help. At the very end, I'm going to go over some software that depersonalizes the saying yes and the asking for help. And I find that real helpful. And number 9, I will find something that I like to do and do it on a regular basis. So before this, as a couple or as an individual in the community, what did you do? What did you enjoy? What did you enjoy together? Write it down. Put it on the fridge. Every week, did I do this? Did I go back to the things I enjoyed? Did we go out and just sit on the patio? Did I go to my mom's real into the special interest stitchery group here? Did I go there? And if not, bring yourself back in line, get on track. Even if you don't want to do it, like a prescription, just take your medicine, go out and do it. I'm sure you're going to feel better at the end. And maybe not at the start of this experience, But towards the end, if you guys take time for each other, take time for yourselves, it'll help. More often than not, when we're moving someone into a care environment, residential care facility, it's not because of anything that's going on with the person who's undergoing these changes. It's because the caregiver's worn out. And it's not the care recipient's fault. It's the caregiver. They will not let themselves do something to lighten their load. So with that, I'm hoping this is the start of a discussion. We're going to quickly go through things. I don't want to read through a list, but I want y'all to tell me, oh, I heard this. I want to know more about it. We can meet for coffee. We can meet during one of the support groups. We can pull people in from the community that represent some of these services and grill them and have them tell us how we can use these strategies and what their services can offer. I'm really big on community organizing, and I'll come up with some ideas at the very end. If there's something that we need to do to make an event or an activity in the community easier on folks with movement disorders, with memory disorders, who may just not present cognitively as the average Joe, we need to do this. My world's autism, and we're real active in if the world won't change for us, we'll make them. So the first question that people always ask me when they walk into my office for any reason is, okay, here I am, what will my health insurance pay for? This is I can tell by the questions that were being asked, this is a different audience than I normally speak to. So all of you can tell me, how much will insurance pay for? Let's talk about residential care. If you need full-time care, how much will your health insurance pay for? I need to hear that stronger. 0. It doesn't, I just come out and say it. And that's a real hard first discussion to have. With the exception of Medicaid, certain Medicaid low-income benefits, there is no option in health insurance for either care in the home, like one-on-one visiting angels. I think every health prescription should come with 5 hours a week of visiting angels. And there's also not a lot for residential care other than Medicaid benefits. You can get home health, and a lot of people don't understand the difference between home health and in-home care. They come in and they say, okay, my home health benefits, I need to have some in-home care. Home health is a skilled service. It's the physical therapists, the occupational therapists, the speech therapists that provide episodic, intermittent treatment. Sometimes it can come with a little home health care aid. Let's say you fall, break a hip, you're rehabbing, you might get a home health care aid. It's not going to be the difference between staying home and not being able to stay home. So I always like to point out the differences. I also like to point out that once you get to that point that you're having a hard time managing in the home, you've not let anybody come in and help bathe you, I'm going to have a real hard time. I mean, my husband and I don't share the bathroom, and we've been married 26 years. So I'm going to have a real hard time when that time comes, but you have to let people in and let people in early. The biggest reason, it's the second biggest reason that people move into residential care is because the physical care becomes too much, and they've not gotten used to having somebody else help them. The time to learn that is not when you move into 24/7 care, and the price tag in the Georgetown area for 24/7 care in a facility, a residential facility, is about $6,000 a month. That is staggering. And very few of us now have the long-term care insurances that are the Cadillac policies of the previous generation. So think about that. This is what you're saving. You have someone come in and mow your lawn. You're saving $6,000 a month. Pat yourself on the back. That's the biggest deal in lawn care. If you're going to send out for some meals, that's what you're saving per month. So as I go through this list of different things that can lighten the load, just say, I could be spending $6,000 a month. What you're trying to do is make this easier in the home so that the care partners can function better. Okay, so last review on home health. One of the largest reasons people move into residential care is because of the loss of their ability to perform activities of daily living. Getting dressed, getting up from a chair, moving. I'm all about getting help early, keeping you mobile, having a psych mental health nurse helping you balance those meds, like Dr. Swallow said, someone who's in the home, who sees how you're helping, needing help during the day. They can both do strengthening exercises, make med recommendations, or just communicate with the physician on how you're doing in the home. and keep you more mobile. Okay, the fun part. When Cheryl asked for a resource list, you know, most of us can reach out for one of the senior magazines that you find at HEB, and there's home health, and there's this, and there's that. This is not that. These are the other things. I had to put in things such as the 24/7 helpline. The other night, I got a call at 11 p.m., which is unusual for me. Someone in the community, where basically it was one of those calls, help, we're driving. And my loved one is looking for something, and it was a delusion, and we didn't know how to stop. We tried some obvious things. I didn't know what to do at that point. I called Texas Alzheimer's. They have a 24-hour hotline. National Alzheimer's also does. I happened to get passed to Christian Wells, the president of Texas Alzheimer's, who sat with me, and we were brainstorming ways to ease this person's mind and help them relieve the stress of the delusion. The delusion will always be there, but you can guide and redirect and bring someone safely home. But I was impressed that at 11 o'clock at night, I could reach out, get someone on a phone. So under hotlines and helplines, these are all the different services that you can call. If you call National Alzheimer's, they can connect you with a social worker at 3 a.m. Yes. You know, Alzheimer's being like 64% of the diagnosis, they get all the screen time and all the credit. But most of the agencies who say Alzheimer's, it's Alzheimer's. If you look in their long version of the website, it's Alzheimer's and related dementias. So they do. Now, each individual person will vary in their skills with something as specific as Parkinson's or Lewy body, but in general, that's usually the things that have you call late at night or early in the morning are shared by a lot of these diagnoses. I've got to put in a plug for our respite groups and their related support groups. I've just seen firsthand how much they do in the community. If you have someone who just needs a little supervision while their loved ones get away, you don't always have to be a participant. You can volunteer and still be in a community that understands you while your caregiver is stepping out to get their hair done or going grocery shopping. Hopefully stay tuned. I know everybody's heard of A Gift of Time. We're trying to start Georgetown's first full-time adult day program in the area. We're still in research and development, but hopefully you'll see a fundraiser in November. My November will be very busy. All right, Medicare.gov. I'm only going to go over one governmental agency because they're pretty dry and boring. But Medicare.gov, if you want home health care, if you need skilled nursing rehab, acute rehab, go to Medicare.gov, type in the facilities that you're looking at, or search the list. It is one of the only places you can get an objective rating system for anybody who receives Medicare and other federal funds. Yelp is great, but you're not going to get a real objective look at how do these people perform under key indicators of quality. I'm a good case manager. I tell everybody, go back to Medicare.gov if you're comparing services of any kind. Okay, I'm trying to cruise toward the more information. Information and education, still on page 3. Those are just some websites that I find I go back to more and more for caregiving support or making recommendations for caregivers or individuals in the community. And one of my favorites is Together in This. I do find a lot of the websites are overly gloom and doomish, and it shouldn't be like that. It should be just more information and how to cope with these chronic illnesses. Together in This, it's a gentleman who, he's very what I call internet-y. Oh, let's have a podcast. Let's have an online chat. And I'm still new to all this. I'm a late adopter. But I really enjoyed that website. I go back to him a lot for checklists, for idea lists. I'm giving you away my best material, actually. I do seminars in some city monthly, and a lot of my material or my ideas come from Together in This. And then I want to, I put some of my favorite catalogs and products, this is not a sell ad. But for example, today I got a call, someone sits in my office saying why they need their loved one to move into residential care, and I'm talking with their loved one and they seem fine to me. We're moving, it actually happens to be a Parkinson's diagnosis, and actually doesn't seem like, I can't measure stress in the caregiver. And then I finally was like, okay, what makes you want to come here today? And the only issue was in the middle of the night when my loved one gets up, they miss the toilet, and I have to spend, an hour or so tidying, and then I don't get back to sleep. There are little devices out there, and there's, for $30 here, $20 there, you can try some and see if they make a difference in your caregiving journey. They won't always. Bring the ones that don't work to the support group and pass them out to somebody else. But in this case, did I say, okay, put your money down, this is how much it's going to cost, move-in's going to be Wednesday? No. I said, you know what? I saw on a website this toilet seat that lights up. It's atrocious. It looks like something out of a Spencer's catalog, and you can pick the color. It can be blue, it can be purple. But I was sitting here going, okay, if it's literally that at night, maybe now after listening to Dr. Swallow, maybe we need to evaluate for a withdrawal time. Is there something going on cognitively at this time of night? But I was like, she didn't want the bathroom lights on because, like most of us, she has a master bath that's en suite. So let's try a light-up toilet seat. It's kinder, gentler, pleasanter. It's like $40 on Amazon. And she's like, let's try this. There's tricks out there that may or may not work. I can't promise you that a Dayglow toilet seat's going to be the end-all, be-all of your caregiving existence. But there's things out there to try. For some people, it's just, I can't keep track. They want to go outside. I hate calling things wandering. When people want to go outside and walk or take care of their yard, I really hate the wandering word. And it usually just means that someone needs to be with me to make sure my decision-making is supported in some of these environments. There are bells, chimes, confounding locks that just take a little longer to undo, something that just gives you that extra time. We're beta testing in one of our businesses. I'm trying to go very neutral tonight here. One of our businesses, it's a watch, it's a pager, and somebody goes beyond a certain perimeter, and I don't own one, your iWatch, something beeps. It tells you that this person is beyond the perimeter that you've put, that they can go safely without having someone walk along. All these things can have a profound impact on the ability to manage something in the home. I put all the different diagnosis-specific groups and support groups down there. There are so many similarities with all these diagnoses and very profound differences. I am sure I didn't get them all. At the end of this little brochure is my business card. If there's something that has really stood out as a help to you, stupid product that really made it different, or just more resources I need to include in this guide, because we are going to link it online, probably over at A Gift of Time as well for their resource guide. We mentioned driving in Dr. Swallow's presentation. It is a touchy subject. There is nothing that will get a family fighting, angry, not talking to each other, is talking about driving. It's really subjective. Just because you can't remember certain things or you have a hard time doing this doesn't mean you don't have that innate ability to drive like you've been doing for the past, 40 years. St. David's Rehabilitation at St. David's Central, which is all the way down on 32nd Street. I'm trying my darndest to get them to have something out here at St. Georgetown Rehab, but they have an adaptive driving program. Whether you're a concerned family member who says, okay, I want you to show me that we're still safe to drive, or if you're the individual who says, I want someone to tell me when I'm no longer making judgments that support my driving skills. It's an OT prescription. Your physician just says, St. David's Adaptive Driving, eval and treat. And it takes about 3 to 6 weeks, depending on their wait list, to get down there. Has anybody heard of this service before? Okay, yeah. Okay, help me bring it to Georgetown. I don't like driving south of Round Rock. But it's objective tests that an OT will do that test your decision making, your response time, your ability to, auditory processing. And they just go down, and it's a very objective way of saying, yes, I still have the skills to drive, or no, I've been advised that maybe I need to start talking about giving up my keys. And they don't report you. Home and community safety programs. Probably the most important on this list. I put some checklists on there that kind of help prepare the home, make it safer. I failed as a nurse. I need to have my nursing license yanked. My grandparents were at the Wesleyan, and I could not get them to give up these rugs that they'd brought back from somewhere in Russia. That's nursing 101, pull up your floor rugs. But these are little checklists that contain similar recommendations. The Take Me Home program in the Georgetown area is probably one of the best when you have someone who just on a bad day, judgment may fail. I'm in the world of autism. A lot of my friends who live in Georgetown have their kids registered with Take Me Home. It's a form online that I linked to, and you fill out a basic profile, biometric profile of this individual. They're this tall, this weight, this hair, this eye color, and then who to contact. And so if suddenly you're at Walmart, you turn around and you don't find somebody, and that can be frightening no matter what their age, and you need to call, or they're doing a code atom in a store, they've got a biometric profile. All law enforcement, firefighters, they can pull this profile up. So if they find somebody who's simply walking the wrong way on one of the long roads in Sun City, which I still do, they can say, okay, this fits a missing persons report, or we're going to look them up by height, weight, and eye color, and they can return them home. Home safety, I'm going to skip that. A lot of this is straightforward. In Parkinson's, one of the key things is timing of the medications. I'm miserable. If I have to take more meds than once a day, I don't know what I'm going to do. I'm no good with meds, and I'm a nurse. If I don't have a gadget reminding me to do something. I've been known to take my dog's meds, just absent-mindedly. The Philips Med Box is relatively pricey. It's $60 to $70 a month for service, plus installation of this electronic device. It will beep. You program what your medication regimens are. They all go into little containers. It's like a little dispensing service. But if your ability to stay at home, especially if you're home alone, depends on a timed medication administration of dopamine, of some of your other meds, this box will ring. And it's like an alarm at a certain time of day. A little dispensed cup comes out, and if you don't respond, it'll stop ringing for a bit, and then it's like your alarm. There's a sleep period that you can program, then it'll ring again. You can set it to an interval of 30 minutes to 2 hours, where after that time period has elapsed, your meds that were not taken go into a discard, and somebody is notified, whether that is your nurse's office, your doctor's office, the nurse saying that so-and-so didn't take their noon meds, whether that is a family member that lives out of town, and they call to make sure everything's okay, and you're like, yeah, I was at the movies, but it can also notify them that something's wrong in the home. A Philips Med Box is, one of the reasons people move into assisted living is because they can't manage their medications. This can be a step between that decision. And it's great. Home health companies can help you set it up, but Philips is also very involved and will get you set up in the home. It has, the one I've seen tested had an adjustable volume, which to me was a deficit, because what do I do with my alarm at home? Turn it down. But yeah, they have it, so you can, some people who have the high frequency loss and the low frequency loss, the model, but this for me was like 3 or 4 years ago. You could adjust it in the back. It is a monthly fee because it's like the life alerts, the various life alert system. It is monitored, and so you're paying $60 a month for them to say, ooh, they didn't take their meds, and contact that other person. House call physicians. I'm not sure in this group we have anybody who'd really need them, but now in Sun City we do have groups of both concierge and traditional physicians that'll come out and see you in your home. Sometimes it's just a hassle to get out there, or it's flu season and you're real susceptible. For many reasons, healthcare in the home can be a really good option as opposed to waiting in a waiting room. I love Dr. Carlson of Be Well MD, but that's just because we've spoken at engagements together, and I know his clinical team, and they're wonderful. There's also a new group to me called Visiting Physicians Association, and they were Johnny on the spot when I put the call out. I tried to call all these different resources to make sure they were still present or still provided service in the Georgetown area. And Visiting Physicians is traditional. Concierge services, you're paying a monthly or a quarterly or an annual fee to have the privilege of being in this physician's practice, and they keep their practice smaller, so they have more time for each call. Visiting Physicians Association was the only group that came out this way that billed traditionally. You don't have any additional fees. They may not be able to see you the next day, but they can usually see you within a week. And as they get more and more clients out here, they're going to have more presence, and that response time will decrease. So they second day aired me a bunch of brochures that I did not bring tonight, but they're very interested, in providing services out here. My favorite things, I don't know, maybe y'all like to cook. more than I do. I was talking to a friend about how my husband usually does the cooking. If something happens to him, we're going to have to, get out the lifeboats. We've got a lot more options now in Georgetown. Now that Randall's has come in, have you kind of seen how everybody's picked up the services they offer? I think Randall's will start having some of these same services, but H-E-B all of a sudden is doing, curbside pickup, where you order online. They'll deliver to your home now. There's 2 groups I've seen here, and I called to make sure they provide service. Shipt or Instacart. Has anybody used those? See, there's always people who are much more techie than I am. But this is something, if I didn't have my spouse at home doing all the grocery shopping and putting everything away, I'd be using these services. Walmart in Georgetown, we use that at one of the businesses I work for. We put in the order the day before, I drive up in 1 to 2 days, and they load my minivan with all the stuff we ordered. It's amazing. And if that can save you in an hour and a half wandering through that white noise of a giant store, it's priceless. Amazon.com. I had my first Amazon pantry box delivery the other day. My cat food, my toilet paper, my paper towels, all that comes on automatic 3-month intervals. This is me getting high tech. And I love it. It's revolutionary. The things I really wanted to brag on are some local businesses. And I'm not picking favorites, but they're just people I use or people I know. Blue Window Cafe over by the Social Security office. Cheryl Beaver is wonderful, and she wants to get into the casserole grab-and-go business. So if you have family covering, you just don't feel like cooking, call Cheryl. She'll put them together. There's a little advertisement at the end, because she does most of my catering when I bring meals to events, and she's wonderful. And she'll do special diets, special requests. There's a little business in in Round Rock. I live in Round Rock. Parents live in Sun City, called the Studio Kitchen. You've got to at least take a peek online. You can stock your freezer with a month full of frozen meals for 3, which means in my house for 2. And Laura Bedson, I've been using her off and on for the past 10 years, 15 years. You just go online and you pick your portions. You can even have them shipped to your house. I used to go and pick them up because she's around the corner from us. But you can have these frozen casseroles for a month if you need to, shipped to your house on ice. They'll stay cold for 24 hours. It's treasure locked away in the freezer for those nights you're just losing it and you need something for dinner. You're going to go crazy. Another thing I have used is called Fresh 20. When my husband was the busier one, right now I am. It's a little meal plan online. There is a fee, but there are 2 people also serve 3 servings. And it's literally, you dial it up, you download it, it's your meal plan for the week. If you're a picky eater, it might be a hard thing, but some of our best recipes and marinades have come from this plan. And if you can eliminate the need to sit down and think of what you need to eat for the next 5 days, think of how many iced teas on the patio, sitting with a book and your loved one, it takes a lot of the pressure out, or at least for me, but I'm stressed about meal planning. I'm going to skip through medical equipment, transportation, almost at the end. Faith in Action, I just can't say enough about those folks. They're wonderful. If you drive for Faith in Action, thank you so much. I had about 4 other people on this list, and I've called them in the past couple of weeks, and they no longer provide services in Georgetown, or they're not providing services at all. A new one for me, and there again, this is just for my interest. How many of y'all have tried Lyft? It's an app on your phone. Okay, I don't feel so bad. Because I just did. My sisters and my brothers, they've been using Lyft, which is an app on your phone. It's a ride hailing. It's like Uber, if you've heard about it. And I heard all the hype about, I don't feel safe. We don't know how their background checked. So I didn't use it for the longest time, and all my family was teasing me. And then what drove me to try Lyft with my kids, I entrusted them to my children, is my daughter just got her driver's license. And she goes, now, Mom, you guys don't have to pick me up when you're speaking late on a Tuesday night. And I was like, why don't we try Lyft? Because our school's on a really busy road, lots of construction, and she's as distractible as I am, and I wasn't quite ready to let her loose in Round Rock. And so my kids now take Lyft when they need a ride that I can't get to, or my son, who has a disability, is still working on that driver's license. We're probably going to be on the 5-year probationary plan there. and he takes it back and forth to ACC. We've had no problems, and it's really affordable. So if you're having to give up a car, or you're driving, or you just want to have a little more independence, if you're living alone and need to get places, Lyft is really good. I would love to see a Sun City app for just a Lyft driver, people that you know already in the neighborhood. You know, someone comes up in a golf cart or a small car. So I think that would be great. A lot of people have told me, I just want to get to the wood shop. All I need is, to get down here. It would be wonderful to be able to use a similar app just in this location. And then I promised at the end, ways to organize help and requests for help. This is one I'm happy to do homework on and come back at another time and teach. The hardest thing to do when you've got something hard in your own life is to say, I need help. And then identify, this is the help I need. And then look at somebody and say, can you help me? There are two apps that they're online websites that really help. And I think in some of these respite groups would be wonderful if we can organize them as a group to put on, it's a calendar. Think of a digital calendar, and you can put on, okay, Thursday, I need a lift to the wood shop. I need a lift to the orthopedic doc. You put on the calendar, and then you hit a button, and it sends your friends who've accepted your invitation to be part of your care calendar or your community. Can say, oh yeah, I'll take you there. Oh, I'll bring a meal on Thursday. Whatever you've put down. I used to call it the casserole brigade. People have babies and you're going to bring casseroles or do their laundry or something. We would use it to put their needs. And the Alzheimer's Association has partnered with one called Lots of Helping Hands. And it's really easy to use, and you can use it in larger groups too, to make that requesting help and accepting help a lot easier. And especially if we met a wonderful Sun City resident at one of our seminars who had her neighbors rallying around her, saying, we're going to keep her and help her be in her home independent as long as possible, but we're having a hard time because I'm spending all my time arranging care. Well, one of these little calendars can take hours of your week of care arranging, out of your lap, and people will happily go around and say, oh, I can do this. I can mow your lawn on that day. So these are wonderful, and I'd love to dig into them and bring them back. These are just some random things that we have used in the community that help free up time and help free your focus to the problems you actually are having or the things you want to enjoy. Quick survey, have I come up with one new one for most of y'all that you haven't heard of? Now, next thing, have I come up with one thing you might try? If I've converted one, it's great. And that's the goal. Please send me ideas that you've seen, you've used. We'll make this a 20-page list for the next time. And I can't say enough. Say yes, accept the help, and help drive. Sun City's really unique in its community. Everybody's active and motivated. If we want to do something where we want to take, Lyft and bring it local, let's try. If we want to have a, first Monday of every other month, Mel's turns the music off so we can bowl in peace, we should do that. Movie theaters, volume down, lights up, first Tuesday of every month. Let's do that. Let me know, and we will organize this and make it happen. So thank you very much for letting me speak. Oh, absolutely.
I'm building a portable library to go to these meetings, and I'm also building a website with this exact information on it.
Not yet. Oh, good point. I'm going to send a copy to Cheryl. You can also just shoot me an email. My business cards I copied on the last page there, and I will send you. This is information everybody needs, and I'll be looking at yours to see what you add, and I will add it to mine. But I'll just send you the Google file.
Thank you very much, Erin, and we'll take you up on that extra teaching thing. A shout out right now, we've had a bunch of help in our programming with our care group and some extended learning sessions. Marilyn Wolke and Dr. Ada Sapp helps me, and Sharon, who's going to come speak to you in just a moment. One of our other nurses comes and helps sit with the patients so that you can come to the meetings. So anyway, without any further ado, Sharon is going to come share about our programs that we have. And I have to tell you that just today, another person called me and said their church would be interested in learning about a program that they could do for a respite. So Sharon will give you a little extra info on that.
Thank you, Cheryl. What wonderful information we've received tonight on community resources and Parkinson's disease. Parkinson's is one of the causes of dementia, but there are many others. According to the Alzheimer's Disease International, dementia affects about 50 million people worldwide, and that's predicted to increase to 131.5 million people by 2050. The total estimated worldwide cost of dementia was $818 billion in 2015. Back in the early 2000s, a need was recognized by the Georgetown community to provide respite care to caregivers of those with dementia. In 2001, the Georgetown Alzheimer's Project was formed. Many of you know Lou Gibson, who's a member of the worship place and instrumental in our respite program. He provided visionary leadership for that project beginning in 2003 as its president. As a result of the objectives set for the Georgetown Alzheimer's Project, Special Friends Respite Program at the Worship Place was formed with Cheryl White as the director. The first meeting of Special Friends was October 7th of 2003 with 7 participants. Today, we have 28 to 30 participants on the roster with a waiting list. It's estimated that more than 200 participants have moved through this program. Also, the first Alzheimer's information seminar was held at the worship place in 2003 with a Georgetown doctor as a speaker. Those seminars have continued annually through the years. In addition, a caregiver support group was formed that continues to meet monthly at the worship place and now includes caregivers for any form of dementia. A similar support group meets monthly at First United Methodist Church in Georgetown. And additionally, a program was established through Special Friends for the formation of new respite groups by local churches. That program offers to provide training, legal forms, and startup funds for churches with an interest in starting a respite group. The results to date have been encouraging. Caregiver respite groups have been established in Temple, Texas, at Christ Lutheran Church in 2006, at First United Methodist Church here in Georgetown in 2007, and also at Wellspring Methodist Church here in Georgetown. Custer Road Methodist Church in Plano established a program in 2009, and in 2015, First United Methodist Church in Denton, Texas established a program. In addition, a church in Florida started a program after receiving information that was provided by Special Friends. Special Friends is blessed to have many volunteers. These volunteers are the backbone of our ministry. They come week after week and provide 4 hours of time to engage with persons with dementia in a structured, purposeful, positive, safe, and social setting. Volunteers provide companionship, craft activities, musical entertainment, kitchen duty, and food for snacks and lunches. Meanwhile, the participants' caregivers are provided with 4 hours of time away from caregiving responsibilities. The need to provide respite care for caregivers of persons with dementia is increasing as the incidence of dementia continues to increase. We would like to continue to expand volunteer respite programs in the Georgetown community. So we ask you to let us know of any opportunity that you are aware of in any church with an interest in establishing this important ministry. On behalf of the Special Friends Respite Ministry here at the Worship Place, we thank you for your support, for your interest, your time and attention, and most of all, for your caring hearts. If you have any questions regarding the Special Friends Respite Ministry, you may speak to either myself or Cheryl afterwards. And that concludes our program for this evening. Thank you very much.